Hi, everyone. Welcome. This is a webinar that is organized by WONCA, World Organization of Family Doctors, the Africa region, to be able to share stories about family physicians who are working in Africa, stories that tell us about what they do as family physicians, a way to share how family medicine is in action, what kind of stuff. So I'm very glad we had about 30 odd people who've registered for it. We'll see how many of you join us, but welcome to all of you. I want to particularly thank Professor Jannie Hugo, who's the head of Department of Family Medicine at the University of Pretoria, and a strong leader and activist in South African family medicine who's promoting the idea of community-oriented primary care and doing some really great stuff with his team and in Tshwane. So welcome, Jannie. Jannie, perhaps you can put your video on and unmute yourself. Thanks, Jannie, for joining us. Really appreciate, Friday afternoons are actually hard to come by. We really treasure it. So thank you very much for taking the time out to share your stories. So Jannie, I hope you don't mind just starting off with some really simple question, like tell us more about yourself. I think some people may not know you. I know you very well, but others may not know you. Do you mind sharing some of that?
Good afternoon, Shabir and other friends. Maybe on a Friday afternoon, I'd rather call you friends than colleagues, but we are colleagues. I'm from, I sometimes start the story to say that I was a home delivery on a farm, but don't go that far. But yeah, I spent most of my forming years at Medunsa as a lecturer with Sam Fearson and the groups there. Before that, I worked in Kwakwa in primary care, rural South Africa. And since 2006, I'm at the University of Pretoria, first in community engagement and then as head of department since 2009, I think. And I've been involved with several national projects and programs. Yeah, I shouldn't forget, Shabir, I remember visiting you in Kokstad in about 2004 when
Yes.
when you were a GP there and I was working with the Belgian people to establish family medicine in South Africa and later in the rest of Africa. Yeah, that's about me.
You're the culprit that changed my course of my life, bringing me to Johannesburg.
By now, you could have been a rich GP. Now you just...
Absolutely.
Yeah. But now that's me. Thanks, guys.
Well, thank you, Jannie, for sharing a little bit about your background. We want to focus. I know there are lots of things that you've been involved in, including the clinical associate program we've worked on and lots of other things. But today, I think you decided to share a little bit or share lots of information about the community-oriented primary care. So where did your journey start, around community-oriented primary care? This is an important part of being a family physician. Tell us about your journey.
Yeah, I think that wasn't really so expected. I mean, when the Department of Health in around 2009 came up with a concept called re-engineering of primary health care, which could actually be also a debatable term, but part of that re-engineering of primary health care was about the development of community-based teams around community health workers, which was called that time ward-based outreach teams. And I was at that time in the Department of Family Medicine with some colleagues here. Most notable is Tessa Marcus, who's a sociologist who worked there. And when we looked at that, she said, but this is what the CARCs did in the 40s. And then we dug up some of that and in a way reinterpreted the re-engineering of primary healthcare as a possibility to implement community-oriented primary care. I must say that in the early days of that discussion, some people in decision-making positions were actually preventing us from using the term community-oriented primary care because they said it was ward-based outreach team. But I mean, that is just an in-between thing. So then we then were also in a position to work with the province and the city to develop the practice and implementation and also the theories of community-oriented primary care. And then we actually, I mean, obviously the history of COPC is very rich in the fact that it did start in South Africa and it was urban and rural. I mean, I think, Shabir, you still have contact with the health services in Alexandra, which was changed that time because of that intervention. So that was the start, and then we just continued with from there, actually to make it an implementation as part of re-engineering. Later, there were this issue of NHI development, and we worked hard to get it into that space. And yeah, this is what we've done.
Yeah, well, that sounds great. Incidentally, Jannie, you had actually prompted my, even though when I was in Kokstad, I think you noticed the strong community links I had. Yeah. COPC in itself as a discipline, you had actually prompted by pushing me to write the article for the Duma Bakwa Award, which I think you've been struggling to get responses, and it was about COPC.
So, oh yes,
I wrote that article.
You wrote it, yeah, Duma Bakwa Award. Yes. Right. You see how easily we forget history.
True, and because of that, I actually looked at the literature, and that's when I said, "Wow, this is very close to what I had in my mind." Anyway, so thank you. You'd set my journey up as well. So Jannie, what do you think? You've mentioned that you all have basically looked at the COCs, and I mean, in the literature, in my own experience, a lot of people seem to have different takes on what the COCs did. I think even at that time, people like Mike Susser had different takes as well. And they were sort of querying, well, what exactly is COPC? And today to the implementation is bedeviled by understanding, well, how do you manage this? What are the principles? How do you do it?
I think what is important for us is to get involved as a family physician meant that we had our interpretation of community-oriented primary care, which was then much, maybe more specifically a clinical element of that, or making sure that it is an engagement in person and not a systems engagement as an approach, and also including the clinical realities of patients. But if we talk about the principles, I think what is the first one is that I usually say that COPC is a geographic game. It is looking at the health of a specific geographical area and the people that live into there. And within that space to assess what are the strengths, what's the disease profile, what is the population profile, what is the access to healthcare, and what healthcare and other resources are there in that geographical space. And I think that is still very important, that you need to make it geographic, because the integration also happens in geography. The second issue, and it's rich in information. Actually, it's about information and how you deal with it. The second issue or second principle that we talk about is comprehensive. Now, for us as family physicians, that's obvious.
True.
That you care for people regardless of what presents, regardless the stage of the disease, regardless the condition, also socio or economic or psychological or whatever, but also comprehensive in the sense that it's from promotion, prevention through to palliation, and that you. So when you look at the care of that community or that household, you look at all of it. Now, why this is particularly important for us in South Africa, and I think the rest of Africa, is because we have been so heavily impacted by vertical programs. And we usually say, in particular, that in COPC you don't do vertical programs. Because that means, and the way that we also try to explain it is to say, if you get to a house and there's one problem, there are usually 4 problems. True. You know, so to now say you deal with HIV, which is the main thing, it just skews things. So COPC in that sense is comprehensive, it's not vertical. The third thing that is important is equity, is when you have that geography that you look at, you have to identify which people need you most, because that's where you spend the most resources. And important that equity is not equality. It's not the same care for everybody regardless. It is the same care for the same conditions regardless of economic status. But actually it means that that part of the society that needs more should get more.
True.
The fourth principle that we talk about is practice with science. That basically means evidence-based, multi-professional. That's what you do. And the last one might also be the most important, is that it's centered around people and households and families, and it's integrated around families. That is where I put in the topic that COPC took us to the homes. So that means it's a family, but it's not just a family in the hospital, it's a family in the home, and that you integrate care around the living space of those people, because we say people experience health and disease at home and at work. So any conceptualization of care or organization of care needs to take that into account. So those are the things that we academically describe as the principles. And when we go into implementation, we just say, all right, how does these principles work out in this specific locality? I think I must say that what COPC is very strong and clear about is there's no fit for all solution ever.
One size for all,
One size for all. It is actually means the locality, the situation guides the implementation.
Which I think brings me to the point, and I think that maybe you can reflect on that as well. Often in family medicine, in the textbooks, it's taught as a cycle. You basically assess the needs, go out and develop a plan, implement it. So it's a very much of a cyclical approach, but that isn't the reality. It's much more complex than that. So how do you see that complexity of developing it? Because you've got these ideas, you say we go out there and you're actually trying to keep those in your mind, and now you are trying to implement it. Any reflections on that? I mean, I actually think that that's quite an important idea, that of systems thinking.
Yeah, I think what is sometimes initially seen as COPC is a big cycle thing. But actually there are big cycles and small cycles and micro cycles within a home.
That's right.
So that, but what I do find useful, especially nowadays, is to look at the angle of complexity theory as a way of understanding what's going on. Because complexity says that things are not predictable and they are not fully understandable, but you practice to see, it's quite interesting in one of the later things I read about complexity theory, they also state that it is the interaction between agents and units within a space. So it comes back to the first principle that it is right. Within a space. But what is important with complexity theory is that you do not have standard plans implemented blindly. It's always in response to what's happening. Complexity theory puts a lot of emphasis on communication, collaboration, and innovation. And it actually sees an organization as constantly learning and adapting to new situations. So what is fascinating is something that the COPC implemented in the 40s is now, in my view, something that sits right in the 21st century in terms of understanding of issues. Because if you look at the development of the hospital industry and that part of healthcare, actually, for a long time, hospitals has been conceptualized and managed as though they are factories. You've got a plan and things just work like that, and that is the end. Where COPC says, no, it's complex, it's interconnected all the time, and whoever works in there needs to respond to that. And then as a family physician, which I think is important to think, is that in complexity theory, they say the interaction between agents are more important than the agents themselves. It means that if you work in an area and the clinic is not particularly good or somebody is not functioning that well, you need not to fix that. You focus on how do we engage with that entity. The same goes for families, etc. So in terms of that understanding, the family physician becomes the major integrator. I think it was a presentation in 2013 where I made the statement that family physicians are not specialists, we are complexologists. And maybe we should recoin that to say
that's true.
that we actually are people who help systems and people to deal with complexity, which basically means you look at the relationships, you look at linking systems and people together, and that is where coordination and those things come here. So I would encourage the colleagues, or friends, sorry, it's Friday, it's friends. I would encourage you to really read about complexity and what it says for us as family physicians in Africa and what we can learn from that.
In fact, when you talk about the way in which you relate to this complexity, we are talking about things that are very much other than the clinical. It's a lot about psychosocial issues. And in that context, there's a lot of, you as a family physician need to understand a lot about the sociology and the politics and understanding how people relate to each other in much more than just simply a family, but community and wider. And I think that makes a family physician skilled in terms of doing that in a community. One of the things that, come to mind, you just talked about the family physician's role. In the COCs, they went out to Polela, and there were two of them, the husband and wife, and they had 30,000 people in that community. And one of the first things when I read, the literature, they actually had two innovations. The one was that they set up what they called a community health center, which was a place where they enabled a nurse and a medical aide at the time, looked very much like a clinical associate, to task them, to shift tasks to them, to enable them to give medical care, clinical care to this 30,000 people who it is not possible to do it. So it's almost like, saying, well, family physicians are not expected, will not be able to, or shouldn't be able to say, I can be the only one delivering the care. I've got to actually enable a team around me. But importantly, is that was for a defined population, was the 30,000 living in that community. And that was the community health center, but they gave that care to them. And I think that's quite an innovation. And then from the readings, they actually then implemented what they call COPC, with 1,000 people each year adding on a new bundle of people. And in that setting, they actually engaged even more closely with community health workers and the community, gathering information, where even in the clinic, the others, 30,000, didn't have any health records, but this 1,000 had health records. Now, I think that kind of situation is fine, but when they reflected on, delivering the medical care, they said that's not good primary health care, just giving medical care. We need to think, like you said, of upstream and downstream causes. Now, in Africa, there's often this question of how do we deliver care to a defined population, and how do we work with teams and integrate care? And often there's these large organizations, like you pointed out, mini hospitals, community health centers function in this very large way, where they function like a hospital, very disfragmented in the way they think, very poorly connected. How do you think you can, your models of COPC try to integrate community or primary, or integrate care using the COPC approach?
Yeah, I think the integration and coordination of care has become more important for us in the last year or two. And at the moment, I think that is the most useful place to spend energy, is coordination of care. It's related to being an integrator, but I saw Bob Mesh a year ago, and I told him that I'm now doing ward rounds in the tertiary hospital, and he nearly fell off his chair.
Yeah.
He said, what happened to you now? But basically we are, it's this, but we do coordination of care ward rounds in the tertiary hospital, having a community health worker team leader in the ward round, as well as, the other OTs, physios, but also the manager of a hospice, for example.
Right.
So, and what's interesting and what we found there is, when we looked at what we did and what influenced the successful coordination of care, of placing people out, it's interesting what we learned is, you ask the patient just two questions: where do you come from, and who's helping you where you are? And in the tertiary hospital, that's never asked. But now actually, even some of the internal medicine registrars would ask that question. What guides that in the end is also a 3-stage assessment, which we as family physicians actually worked out. It is the 3-stage assessment that guides that. So care coordination starts also in the hospital. And I would advise colleagues that are in a situation where you work with a hospital, it's not to go and to do a ward round to solve necessarily health problems or clinical problems, but you can solve that also. But it brings in the whole view that this person has got a home. I mean, we joke on the ward round where I would say to people, but now you're discharging this person to the parking lot, because that's what's often done. You think there's a parking lot, but nobody lives in a parking lot except the homeless people. But so I think coordination of care is something which our other specialist colleagues actually need and understand, and they can develop. So I think for me as a family physician, it gives me a very clear position, even in a tertiary hospital, but obviously with the other hospitals. But then if you go to the homes, to the streets, to the families, then the game changes a lot, because there is what you say, it's the NGO, it's the church, it's the politician, and this is where we then have the as part of that, you can call it a multidisciplinary team, but it is basically building a system of engagement of the main players at the level of the community, which then shoots into the hospitals and the hospices and other places, but it lives in the community. And usually there it is also a matter of who are alive and who are integrators. You don't necessarily look only for this profession or that profession. You basically ask the question, who are integrators around me? And you strengthen and you work with them, and they sometimes do the most amazing things, you know. So that is where coordination of care and integration becomes a major field. And I see there's quite a lot of publications nowadays about that. And I would say as family physicians, we should engage that process and we should take lead there.
Yeah, yeah. Well, that's very interesting. I mean, you say you've been able to do that with the hospitals. Is that not a function of the fact that in Tshwane, you'll have got an extensive network of community health workers, family and team leaders in the community with which you'll have linked up very well? Is that not, and if you were to advise how family physicians could build that and link it up to the hospital, what would your advice be? How would you suggest that be done?
I think if you just sit and think for yourself, the richness of your own knowledge of the situation. I mean, I'm just amazed when we go on those ward rounds. I think we have wide networks. I mean, there's a patient that comes from Limpopo, from a certain village, but you know that, or you phone Gert Marinkovic and you ask, Gert, who's near in that hospital?
True.
So you can refer them. But what is basic also is to say, when we go into the hospital and we see that, we know that most of the city, most of the district there are community health worker teams there. So it's possible to actually say, all right, where do you live? And with the community health worker team leader, she's got the contact with everybody else. You can actually not just write a letter and say, go to the clinic. You say, this person lives there, this community health worker will visit you. So I think it is also the specificity of the care. And that is what yes. It is integrated around people and family. It's not just a concept, you must refer, there's a letter, go and see somebody. It's the specificity. And for that, you need to have a system and at least know who's where. And in that sense, you can really assist massively in making systems more efficient.
I mean, and in a way, across the country, there are lots of these community health workers out there. Like you got in Tshwane, perhaps the issue is family physicians just need to reach out link up with them and find ways in which they can step up the education, coordination of them, and find ways to link that into the hospital like you have done. So, you know, if you were to take, so in a nutshell.
Let me just say
Yeah,
there,
go ahead.
Shabir, on the issue of community health workers. The one thing that is clear is the better the community health worker is supported and trained by a clinician from our side.
Yeah.
The point is what gives them credibility is not necessarily their success in prevention, which may be the most important, but you get credibility on people who are ill. And if you support that community health worker and they can do things, then it raises the whole profile and reputation of COPC in the community. So you should, ideally, the community health worker should be able to phone a family physician and say, I've got this problem, and then you help them. The other thing of the community health workers, I usually say to people, doing a home visit is like doing a laparotomy in an acute abdomen. You can have lots of other information, but the moment you open that abdomen, you see what's going on. And that is what a home visit is. And we as family physicians don't have the time and the abilities to do many of those. I think we should do some. But the community health worker basically lives in that open abdomen all the time. And we need to support them and work with them. And I think that is where the link, it comes out of the tertiary hospital all the way down to the community health worker. But sorry, I was interrupting you.
No. I think that's, you know, that idea of the complexity of simple care in the community. You know, what we might think is really simple care is actually very complex space, which requires us to be astute to many things like you've raised. So where has COPC taken you in terms of your journey that you've described? I mean, where's the department at, and yourself or the space of Tshwane at in terms of COPC? What have you achieved?
Yeah, it's not. Yeah, it's a mixed bag. It is a mixed bag. But I mean, we did between 2013 and 2017 work with funding from the city of Tshwane, and at that stage we had 470 community health workers who did most of Mamelodi and some other areas. And we really developed quite a lot of our thinking and practice around that. But we also learned the mistakes and the fact that you need to have a reliable system to sustain gains. I think that's what.
What do you mean by reliable system to sustain?
What we said from the beginning is that the community health workers needs to become part of the health system. What we saw that time was all these things happen with the community health workers, and they have to go with every flow that's there, and they are not often well paid, they don't have security, and also government policy in terms of the re-engineering was shifting every now and then. This PEPFAR partner would come in and want this, and then there's another funding from another PEPFAR thing. That instability is not good for COPC. So, but I must say, it's quite remarkable that we started off with community health workers sometimes have a stipend, and in Gauteng now, they are actually appointed as permanent employees. Now, that is the type of stability that you need. Obviously, you need education and support and things like that. But this is what I mean in terms of stability and predictability. Okay. For example, you and I worked hard to get COPC into the NHI, but it doesn't seem as if the NHI movement is really interested in implementation.
Yeah.
That's what I mean, is that often, and I think this is where family physicians and universities can play a role, is to provide some continuity of ideas despite other instability. So then that was the one thing. But one of the most unexpected journeys that it took me on is that of drugs. So what happened with our COPC, and this is why I am actually so committed to COPC, is because you start to see what goes on. So when we get into households and to streets, we saw the substance use problem. And it was huge. Homelessness, substance use, and what goes with that. Fortunately, at that same time, the political leaders in Tshwane wanted to do something. And we had a relationship with them, with the COPC. And then they said, all right, let's work out a community-based substance use program. And that is when we started working out what we now call COSAP, which is the Community-Oriented Substance Use Program. And we're now entering another 3-year project of that, where you use the principles of COPC in substance use. It is not easy, it is not simple, and you actually needed a better overall system. At the moment, we are looking at homelessness and substance use as next to each other problems and interventions with that, and asking how would you take homelessness in a COPC approach. The other thing that lies with this, which we need to discuss at another time, is mental health. Mental health is a huge problem, and we need to find a COPC approach to deal with mental health. So that was the one route that I thought it's good to mention, that if you have a big problem, I'm talking about you guys working out in many areas. Just ask yourself the question, how would COPC approach change the way we do with this problem? You know, I think if we address TB, for example, explicitly from a COPC approach, we'll do much better. I mean, there's even evidence that it's much better. But the problem is, with many health issues, people think from institutional sides, how will we do that? So that is the COPC. But the latest one that is quite interesting is we engaged with the mines over several years, trying to explain the idea that if the mine wants to do something for the community surrounding the mines, which is a highly problematic community, is a highly difficult situation, because actually the mine brings in money, but the mine takes away life, it takes away land. You know, it's highly problematic.
Yes.
So what we said in discussion with the mines is, let us help you to spend money in COPC implementation in the community surrounding mines. I mean, the mine would often build a clinic or build a school. Many of those 3 years later are empty because there's no staff or whatever, you know. And somehow one of the mines in Limpopo and Mogalakwena took that on, and we started to implement COPC in 3 clinics near the mine, and we appointed a clinical associate, and we worked specifically with the local health service, community health workers, whatever, and we did what we then called integrated COPC. So it engaged the hospital, the different hospitals, the mine health service, the clinic, the community health workers, but we made sure that we supported the community health workers. And this was sort of end of 2019. We started getting going nicely. And beginning of the year, it's COVID.
Oh, yeah.
And you know, COVID for the mines is disastrous, because the mining practice is very vulnerable to COVID. And this particular mining company, Anglo-American, we had experience with them, and the next moment they said, no, let's go in partnership. And at the moment we are working in 24 mines, all Anglo-American and De Beers mines in South Africa, in the communities next to them. And we do a COVID intervention, which also is very interesting. The mine service is, the mine health service is well established at mines. Mines are very good at occupational health. But now the person gets ill or diagnosed in the mine, what about the community? So the first part of our intervention is the clinical associates would go and do a home visit, do the swabbing, and care for the people. Even if they need food, they will take food, they'll take the medicine, examine the patients, they follow up, etc. So that is the one part of it. But the other part of it is purely COPC implementation. And we have appointed, I think at the moment, around 70 clinical associates that work in many of these communities, building up relationships, do training, and as a COPC development. And we see this as a very important opportunity to implement COPC and show the impact of that, because that is the other problem. Remember, the CARCs only had 15 years to show what they could. I mean, we haven't had 15 years yet. We had 8, 9, 10 years, which of half we've wasted. But the point is we need to find a place where we have reliable partners that we can show what is happening. So that's what's happening there. And yeah, this is
well, that's wonderful. Yeah, that sounds like huge progress. I mean, embracing the mines, and I think you have promised to share the sort of the drug abuse issues in another webinar, which will be great. And I think that that'll be really handy. But I think this sounds like it's going places and helping you. I think that key thing is like you said, trying to prove the outcomes, that it does indeed add value. Often it's easy to, it makes sense, but often the decision makers need to be given economic cases, business case to say, listen, this does save money. You did have the ITA program. I just thought maybe I'd use this opportunity to find out how that's gone. How is it, is it actually panning out right? I know there was some challenges with the clinical link that you were having. So has it panned, or are there some new thinking around how you integrate the care between the clinics, sort of facility, service delivery there, and the community?
Yeah, I think we.
Perhaps briefly, you could just mention what it's about.
No. I would have said 2 years ago in this talk, I would have mentioned the technology and the IT in the 3rd or the 4th line.
Yeah.
At the moment, I am aware of the difficulties surrounding it. We had a lot of success with ITA in a stable situation, where the funding was there. And I mean, we have made assessments of the health of, I think, around about 400,000 households with more than 1 million people, and lots of information. And we could identify a lot of issues at home, not immunized, not going to antenatal care, TB, etc., etc. And that's happening, and that's possible. The problem with that is you need to do it at scale, and the government needs to fund it, because the university can't fund it. Where we have our small community where we do it, we fund it and we do that. But the problem with ITA specifically was integration of care and linking up with other systems. Again, when we started with ITA, we worked strongly with the CSIR, and by that time there was a promise, a conceptual promise, there's even documents that there will be a health information exchange that would be able to connect everything to everything. And we prepared ITA for that. that didn't materialize. So what is needed is actually a system that can move from the home to the clinic to the hospital and back. And we're busy with designing that. And actually, it's quite interesting. We just decided this morning, and we will invite you, that we actually need, I mean, in the beginning of December, we're going to have a day workshop to present all the systems in South Africa that's being used, because there are different strengths and different weaknesses. But information technology is very important in COPC, because that is how you can move data. Unfortunately, ICT is a difficult animal. It is often expensive, and it is not an easy story. And I think we will have to work together. And there's also lots of interests and that. So I think we definitely learned a lot, and at the moment we are working on different systems, including ITA.
Well, that sounds great. I mean, I think there's challenges a lot, and I think just sharing that, I'd love to be part of that day workshop, and I think sharing experiences is really the way to go. Well, how do you see the future, Jannie? I mean, we're coming to the end of the hour, and if you were to say how things look for the future for COPC, your experience, your insights, where are we going?
What is important is for us to engage the registrars with COPC. They often go further than us as consultants, because we are often quite set in our ways of thinking. So I think in future we should build COPC practice more specifically into the registrar programs, with the view of seeing how they develop. I think in terms of the NHI type thinking, you may even think of giving a registrar a clinic area and say, this is your practice, and continue with that. I do think we need to revisit this concept that the registrar can learn through rotations in specialist departments or hospital departments. I think we should make COPC the basis of practice, and then the hospital rotations something else. So this is something I see for the future. I see for the future that family physicians should, and now I'm talking about the private sector, actually family physicians should explore to create their own practice of community health workers visiting their patients. I think we should seriously engage with technology in future, actually point of care testing, distance sensing, wearables. I think we are lagging behind with that. We should be leading this thing that, I mean, the diabetic should have the technology where the glucose is measured continuously and you help patients to care that. So maybe the point of that is that COPC fits perfectly with patient-led care, where the patient takes charge of her care with the support of the family physician, but having a community health worker as a person who's also sometimes visiting there. But I think we need to push that, and this is why I'm saying let's get the registrars in there. Some of us are slow in that, and we should find partnerships with technology people and build that in. But for that you need to be very strong in your thinking. so that it's not led by the technology, it's led by care, but the technology is part of that. And then also, I want to repeat, as family physicians, we should become excellent complexologists so that we can respond. Yeah, I must mention that. That's my latest idea, that we are preparing through COPC for the next pandemic. And this is what we say to Anglo-American, is if we have these systems in place in the communities around your minds, the next pandemic, we won't have to fall around with things.
Yeah.
We have a system. So we should perhaps promote COPC as a response to pandemics and disasters.
Very much so. I mean, I think you point to something that I also find quite challenging, is the way in which we are training family physicians almost. And I think it represents some of the, response to system. We feel very comfortable in facilities. We feel very comfortable in hospitals. Our training seems to be responding to the health system saying hospitals is where we needed. And this is the rotation that everybody's so obsessed about, but not a very strong community base. And in that community base, how do we get our registrars to actually have a strong foundation in that space? So I mean, as in Johannesburg, I'm often struggling with that concept of rotations being a bit of an obsession into the hospitals. Well, Adam Asgar, I'm not sure that you know him, but he's from UKZ, and it seems at third year registrar. He's asking a question, Jannie, to you. What is a good place to start as a registrar? I have identified a clinical community for my COPC project next year as a third year registrar. What should my next steps be? Jannie, what are your reflections on that?
Yes, Adam, you are there. The point is, negotiate with your lecturers and the local people. Say, I want to be the COPC practitioner for this area. And I will go it all the way through. Care coordination is going to make you having the reputation, the fact that you can go to the clinic and the hospital and the home. So make some time to go to the hospital to see your patients. When any of your patients are admitted, phone the guy and say what's going on with my patient. And tell them in the hospital, when anybody is from my clinic area, please inform me, because I'll make sure that the care is, because that buys you credibility in the health system side. And then you focus on the community health worker teams, teach them, get the resources. You know, Tessa Marcus's book on the practical guide for COPC is on the net. It's freely available. Set up a training plan for the year, not just for the community health workers, for the clinic staff, etc., so that you all start to talk the same language in COPC. So I would say do a big bang and see where it leads you, because COPC learns where they are, and support. And if you need support from me or Shabir, you just phone us. But I mean, you've got very strong people there in KZN. They will guide you, but be bold and make sure that you take care of individual clinical elements. And I think that's the point I want to agree with you, Shabir. You must know your practice in terms of how to manage TB and diabetes and that, but not to be able to sit in a hospital and be clever. But that patient at home, you need to be able to manage. So you need to know your clinical medicine. But knowing your clinical medicine and not knowing the home, it's useless.
Yeah. In fact, Jannie, I think Adam's just shared he's in Groundville, Kwadakuza. We'll just get a little bit of information about it. But one of the challenges, and I can't imagine Adam being able to work this out himself, you know, the idea of a COPC assignment, which I think he's pointed out, the college has actually said COPC needs to be an assignment. And quite frequently, what the departments are doing is saying, well, go and find some time, one of those rotations for sometimes a month or 3 months, and go spend some time there. But I mean, how do you actually, can you actually do something like go and spend 3 months and understand COPC? To me, I struggle with that concept. And in fact, globally, there's a strong element of not necessarily COPC, but practice-based sort of links in the registrar training or you know, resident training. Quite often in many parts of the world, they have a registrar that is attached, like you said, to a community on day one, to a clinic in day one, or a practice. Not necessarily the community orientation being there, but a practice. And then they go down to that clinic actually every week while they do other rotations. But because they're there consistently over a time, can be even up to, you know, in the 3 years, the entire 3 years, they're able to do what you've just described, being able to put together ideas, connect with the clinic, connect with the community. All that can happen. But the registrarship in itself, as it's seen with this registrar rotation of 3 months for COPC, to me is untenable. It actually defeats the idea. I don't know what your thoughts are, but I certainly hope we can agitate in the college and, you know, amongst the departments to say, this is not acceptable. What do you think, Jannie?
I think the point for Adam is retrospect is always easy, but it would have been nice if you were placed there 2 years ago.
That's
what
right.
we do, which often is we first put the registrar in the community and then later into the hospital. And that seems to work better. But you also have to be supporting them. You know, sometimes if you don't support them, they also get lost. But what I do want to comment and agree with you, Shabi, COPC is not a glorified quality improvement project. And sometimes these COPC projects write-up is slightly theoretical and it's superficial. It says there's a community, make a community diagnosis, and now you say, all right, there's nutrition is a problem, let's make a garden at the clinic. But actually, it is not, you need to go into the homes. Kwadakusa is...
yeah, I'm just pulling up the map.
My daughter was living in Belito sometime, and I paid the accounts to Kwadakusa.
Right, so it's up north.
Dolphin Coast.
I'm just trying to get a sense of its geography. But, you know, if I were to suggest, I think as Adam, Asghar, I think that, you know, defining the community, I think firstly, you know, Jannie can suggest further, is it would be to go into that community, into that clinic, spend some time understanding the dynamics, particularly with community health workers, facility manager, and the team. If it's a small enough team, that shouldn't be overly difficult. And from there, you can, you know, look at the work of the community health workers, link up with them, gather the information that you have, and then be able to see if you can gather information. But like Jannie says, you know, within 3 months, you're going to find if you really have to think hard, it's going to be pretty limited for you to become a strong expert. And if you spent that 3 months over 3 years, you'd have had a much better outcome. And that's our concern. So there's some tips for you. Jannie, any other tips you have for him? I think he mustn't have a high expectation of achieving major thing in 3 months. That's just our thoughts.
Yeah, I think what you will learn in 3 months is yourself. I mean, if I talk about our registrars in the lockdown times, we had 4 or 5 of them working in the homeless shelters, and it was quite difficult. But afterwards, they say they would have never learned that if they did. So engage yourself, make sure that you learn and support other people. But we could always engage with you. At least you can identify the community. You could, yeah, no, you can.
I would suggest. I would think he's got a fairly smallish community that could be defined by that population, catchment population of the clinic. But go and dig in. I think the guidelines that are there, and you can look at what Jannie. I don't know if you have materials online that you'd recommend people look at, but on the website profmusa.com is also
the easiest is to go to ResearchGate and look at my name or Tessa Marcus's name.
All right.
And you get some material. Our website is not up to date enough, but there are all the articles and the guides.
Right. Well, thank you very much. I don't know, Jannie, if you have any other comments, but this has been really helpful. I think we've gotten a sense of what you've been busy with in Tshwane and beyond, and some really great stuff that I think we'd love to get more about. I don't know if there are any other questions. I don't see any hands up or any questions in the Q&A or anything added to the chat room. I'm assuming that people have enjoyed that. I have certainly. Jannie, once again, thank you. Really appreciate you spending your time. It will be recorded. It'll be out in a post that is the same post we've shared with you now. So, if anybody wants to look at it again and share it with anyone else, feel free to go for that to that post, and I'll maybe post it up here. But if you go to profmusa.com, look for webinars, you'll see this one there, and it should be up pretty soon. So let me call it a day there. Thank you, Jannie.
Thank you very much, everybody. I enjoyed.
And really hope you can share a little bit more as we're going along. So we'll see perhaps one of your colleagues or yourself in 2 weeks' time, 3 weeks' time. I think we'll share more. And please do let me know about that workshop, and we can take it further. To everyone else, thank you. It's been great having you around. Please be safe. Enjoy your weekend. Bye-bye.